your range of motion, you're going to damage tissue. You're not stretching, you're hurting. Don't do it. So when I said earlier that I want you to be able to recognize scuffies and FAI and labral tears, what I want you to do is be able to tell people, don't do that. What are you doing that for? Oh, I got a groin strain, man, I'm going to stretch it out with it. No, you're not, okay? You're hurting yourself. Stop, please stop. And in general, as a stretch, like of all the positions that people put their body in when they think they're doing stretches, these stretches that involve flexion, adduction, and internal rotation of the hip, it hurts me to watch. It's like, why are we doing this? Why is this part of this exercise class? So, I mean, I told you you can fracture your greater trochanter landing on your hip, and my buddy did his, and you can fracture your pelvis, and I know I micro-fractured mine. So landing hard on your side, aside from getting these soft tissue hip pointers, you can cause significant bone and cartilage injuries. You can tear your labrum acutely in a number of ways. You can tear your labrum acutely with what's called a dashboard injury mechanism, where your flexed hip is driven posteriorly. So in a car accident where your knee hits the dashboard, or if you fall down and land on your knee, when you drive the femoral head back this way, the capsule pulls the labrum right off the acetabulum. Or you can over-rotate, so an external rotation injury where someone's caught up and they're knocked backward like this and their hip hyper-external rotates, they can tear their capsulolabral complex. But labral disorders are more often not acute dashboard or hyper-external rotation injuries. More often they're caused by repetitive femoroacetabular impingement, chronic overload. So repetitive FAI, or always pinching, doing this all the time, dancing the can, whatever, not good for the hip joint. And this is real common stuff. So just about everybody who has hip pain or hip arthritis has a torn labrum. It's sort of part of the progression. If you keep on pinching your hip joint, first you tear the labrum, then you damage the joint surface cartilage, then the doctor says you have arthritis. But the first thing that happened, probably most often, is the labrum got torn by being repetitively pinched. People will complain of groin pain. They'll say they have pain. Oh yeah, I've got a strain in my adductor. No, they don't. They've got a labral tear. Maybe they've got a groin strain. Needs to be properly diagnosed. Everybody who has pain here doesn't have a groin strain. They may have a hip joint disorder. And with labral tears, they will often feel that it occasionally clicks or pops. Now I'm freaking a lot of you out because a significant percentage of the population has FAI, but a significant percentage of people also have benign snapping hip syndromes. And so just because you feel clicking here doesn't mean you have a torn labrum. If you have clicking here and you have no groin pain, you probably don't have a torn labrum. If you have clicking and pain, you may, and you should get checked out. If you just have clicking and no pain, you probably have a snapping psoas tendon. If your iliacus and psoas are under excessive tension, there's a little tubercle here, and the iliacus and psoas tendon run medial to this little tubercle, but when you externally rotate your hip, the tendon can snap and forth back across the tubercle. So that's called a snapping psoas tendon, and very hard to tell because it's right above the hip joint. So how can you tell the difference between a clicking labrum and a snapping psoas tendon? They're right in exactly the same spot. Putting your finger on it and saying, oh, it's right there, doesn't help because they're both right there at the hip joint. And really it's about whether it's painful or not, and whether your hip extension is limited because your iliopsoas mechanism is too short and tight, etc. So it should be assessed, but don't let me freak you out just if you've got snapping. If somebody's got a badly torn labrum, even when their hip is in extension, if we internally and externally rotate their hip, it hurts. That's called a log roll test, where they're lying down and we just roll their hip back and forth. And they go, oh, that doesn't feel good. It's like, okay, you got problems. The impingement test, where we flex, adduct, and internally rotate them, so we'll take their leg up, adduct them, internally rotate it, and they go, that hurts. Well, okay, that's a positive Fadir test, okay? Rarely is Faber provocative. favor is flexion, abduction, external rotation, so the figure 4 position as opposed to the can-can position. And then we got to take fancy pictures to verify the diagnosis. So it turns out that while just about everybody can cause FAI if they, not stretch, if they push fadir. Like if you go far enough, you can cause problems. But people who really have this problem get impingement in an abnormally restricted position. In other words, if you feel a bit of pinching in your groin, but you're fully flexed, adducted, and internally rotated, that's not what we call FAI, that's a normal hip. People with FAI get that problem when they flex and just barely start to adduct and internally rotate. In other words, they have restriction of fadir. They have an abnormally limited range of motion of combined flexion, adduction, and internal rotation, and it causes discomfort if you put overpressure on end range of that movement. So it is restricted, okay? That's the key. So anybody, and the worst cases are what we call the obligate external rotators. If you know somebody, and it could be yourself, who cannot squat without externally rotating their legs, they probably have this problem. Because when someone tries to squat and they flex past 90, if their hip is not abducted, well, people with FAI can't do that. So as they flex, they are what we call obligate external rotators. And their leg will do this. And they will have been told that they have a tight groin and need to stretch it, which is just complete and utter nonsense and poppycock. Obligate external rotators, people whose legs veer off to the side when they flex them, have abnormally shaped bones. They have this syndrome called FAI. There are 2 subtypes. There are 3 subtypes. We classify them as 2 subtypes. The less common subtype, stupid names, it's called pincer type. It should just be called acetabular FAI, is an abnormally large acetabulum. So imagine, and this model here doesn't have it, but imagine that the acetabulum was on steroids and grew too large so that it hung down to here. If it extended out another centimeter, then no matter how I tried to lift my hip up, I wouldn't be able to because the socket is overhanging too much. So it's an excessive overhang of the socket. There's actually an opposite problem called congenital hip dysplasia where the acetabulum is too small and it wears out the hip joint because the contact patch is too small. So we want to have an acetabulum that's just the right size. Not too big, which causes restricted movement, and not too small, which causes the joint surfaces to wear out because the contact patch is too small. They each have names. Congenital hip dysplasia is the small acetabulum, and excessively large acetabulum is called pincer type FAI. The other type, which is much more common, called cam type FAI, should just be called femoral FAI, is where the femur is shaped abnormally. The acetabulum is normal. And there are actually 2 different variants of abnormal femoral head shape, but the most common version is, I'm going to draw some pictures of it, because my pictures aren't great here. I mean, they show it, but they don't really do justice to it. So the key here is to recognize someone who has a restricted ability to, once they flex their hip up past 90, it'll start to go off to the outside. They cannot adduct their flexed hip. And the combination of all 3, adduction and internal rotation on top of flexion, will drive them through the roof. It'll cause pain. But they have restricted fadir and painful fadir, where they complain of groin discomfort if you put overpressure on fadir. So the pincer type is this abnormally large acetabulum, and if I try and lift this femur up, it's going to hit the roof here, right? You just won't have the capacity to lift that femur up with this big acetabulum, especially if you may be able to flex it, but then if you try and internally rotate, you're going to jam the femoral neck into this excessively large acetabulum that's sticking in the way. You're not going to be able to internally rotate that flexed hip. Cam type, and this picture really doesn't do it justice, is where the acetabulum is normal, but the femur gets in the way. Now, this makes it look like there's just this bump there. And that bump, and it's called the cam bump. Cam is an eccentrically shaped circle that, the camshaft in an overhead valve car or whatever. That's what a cam is, and it's a type of machine or wheel, but an eccentric or off-center wheel. So this is an off-center femoral head, a cam-shaped head. It's not round. It's off-center. It's said to be an eccentric femoral head. And I'm going to draw a picture on the blackboard to help a little bit more. So if you look down, and it's interesting that this skeleton, which is actually a plastic model based on a real human, it's got FAI on the right hip and no cam type FAI on this side. This side actually has FAI, and you guys can't see it from where you are, but I can. I'll draw a picture. What you want to do is you want to look at the femur from the top, like that. So when we take x-rays and CT scans, we're looking down at the femur. And if you look down at the femur in an axial plane image, in a normal femur, a shitty drop drawing a circle there. It was supposed to be circular. But the center of the circle should be in line with the center of the neck. Okay? So it's like, I remember once as a kid, I was getting a treat at the Ottawa exhibition, Eastern Ontario Rex. I lived in Ottawa. My mother bought me an ice cream cone. And the person slopped the ice cream on top of the cone so that it was hanging off one side, And being an obsessive compulsive kid, I was like, I don't want this ice cream cone. Because it's off center. Right? And she's like, okay, put the blob back in the center, right? So in the hip joint, you can do the same thing here. Right? If I've got a femoral neck, and I put the circle here so that it's off center, this person gets FAI. Because when they try to lift their hip up, the acetabulum is here when they're in a position, the acetabulum should be coming this way, okay, the socket's there. And now, if I lift this up, this femoral neck is supposed to be down here, but now there's a lack of space because the stupid femoral neck is in the way. And it bumps into the acetabulum. And the more it bumps in, the thicker the bone grows, and then you get this big bump growing there. So the so-called cam bump isn't present at the beginning of the problem. It's present after years of the problem. The more you pinch it, the thicker the bone grows. The thicker the bone grows, the more it gets pinched. The more it gets pinched, the thicker the bone grows, and the thicker the bone grows, the more it gets pinched. You ever seen a dog chasing its tail? This is one like that, okay? It's a self-propagating issue. And the more people experience hip impingement, the more they're going to have the problem. So it starts as simply an off-center femoral head, but it gets worse and worse because the off-centeredness gets worse and worse